Class, and welcome to part 2 of chapter 17, where we finish up talking about the heart. And this part will go over all of the electrical events of the heart and describing what that means. So your heart itself will depolarize. That means an electrical current will go through it and will contract without nervous system stimulation, although the rhythm of heartbeat, whether we increase it or decrease it, can be altered by the autonomic nervous system. So the coordinated heartbeat is a function of the presence of gap junctions that are found in the intercalated discs to allow the heart cardiac myocytes, muscle cells, to contract as a unit, as well as the intrinsic cardiac conduction system, which is a network of non-contractile autorhythmic cells that will initiate and distribute or spread out the impulse to coordinate the depolarization and contraction events of the heart. Action potentials are always initiated by pacemaker cells, and cardiac pacemaker cells have an unstable resting membrane potential called the pacemaker potential or the pre-potential. There's 3 parts of the action potential of the pacemaker. I don't think I have you guys know these exact specifics, but we have the pacemaker potential, causing the interior to become more positive as we begin the process of initiating an action potential. Then we have the depolarization phase where calcium channels open, calcium increases into the cell, leading to a rising phase of action potential, and then repolarization where potassium will leave and the cell becomes more negative again. So you'll notice it's a similar action potential peak of cardiac pacemaker cells that we've seen when we've studied action potential in your nervous system. So you don't necessarily need to know those exact details, but just know that these pacemaker cells have a depolarization and a repolarization phase as it spreads out the impulse of electrical activity throughout the entire heart. The sequence of excitation, so your cardiac pacemaker cells will pass impulses in the following order, which you should know, across the heart in about 0.22 seconds. So they start traveling, or they start in the sinoatrial node, which is the pacemaker of the heart that starts the heartbeat. Then those pacemaker cells pass this impulse of excitation to atrioventricular node. The atrioventricular bundle passes it to the right and left bundle branches, and then it gets passed on to the Purkinje fibers. So you should know that order, and we're going to go through that order right now a little bit. The SA node is the pacemaker of the heart found in the right atrial wall. It generates impulses at about 75 times a minute. And the impulse will spread across the atria to the AV node. From the AV node, which is located in the inferior interatrial septum, from here, the electrical impulse is delayed about 0.1 seconds. And this is important to know. There's a little delay where the electrical kind of passageway goes from your SA node to the AV node. Right here, it kind of is delayed. Because the fibers are smaller in diameter, there's fewer gas junctions, but also this delay is important to allow the atria to contract completely to try to get as much blood into the ventricles as possible. So this little delay allows for kind of filling up of the ventricles before the ventricles will contract. Then the electrical activity is passed to the AV bundle found in the superior interventricular septum. This is the only electrical connection between atria and ventricles. And then the signal is passed to the right and left bundle branches, where they'll branch into the interatrial septum to the impulses, carrying the impulses to the apex of the heart before branching into the Purkinje fibers, or the subendocardial conducting network. And it's at the Purkinje fibers that will bring the electrical signal to all of the ventricular walls. So this is the more kind of elaborate. It'll be more elaborate on the left side of the heart because the left side of the heart is thicker. But from here, the Purkinje fibers really take the electrical signal to all of the cardiac myocytes found in the ventricles. Ventricular contraction will immediately follow as it travels from the apex toward the atria. And again, the process from initiation at the SA node to complete contraction takes about 0.22 seconds, so about a quarter of a second. So this is a great picture. I think on your next lecture exam, I show you a picture like this. So you have to label the different parts of the action potential succession during one heartbeat. We start in the SA node where the action potential begins. Then it travels to the AV node where there's a little delay. And again, kind of backing up a minute, as this electrical activity passes through, we call that depolarization. So the passing of an electrical charge is depolarizing. So once, the charge passes from the SA node to the AV node, that depolarizes the atria, and then the atria will contract and squeeze all the blood into the ventricles. And again, this little delay here or pause before going into the AV bundle is important to allow to complete atrial contraction to fill up our ventricles with as much blood as we can. From here, the electrical activity passes to the AV bundle, which is kind of at the top part of that interventricular septum. And then it gets passed down to the bundle branches where it will divide, and then we'll get passed to the Purkinje fibers. And again, the Purkinje fibers kind of head down to the apex and then travel up the walls of the ventricles to kind of bring that electrical signal to all parts of the cardiac myocytes in the ventricles. And again, once we depolarize all of the cardiac cells in your ventricles, then the ventricles will contract. And again, this all takes about less than a quarter of a second. Some imbalances. So we have a lot of imbalances that have to do with the heart's conduction system or passing on of this electrical activity. And arrhythmias, any irregular heartbeat where there's uncoordinated atrial and ventricular contractions. So normally we always want the atria to contract and the ventricles contract. But if we have kind of some arrhythmia where their contractions are not occurring at the same time, it means we have a problem somewhere in the electrical activity of the heart. Fibrillation are rapid irregular contractions where the heart becomes useless for pumping blood because there's no regularity in the contractions. The circulation of blood will eventually cease, and it usually results in brain death when no blood can get up to the brain. Treatment is a defibrillation. So if any of you, have taken basic life support training, you know where the defibrillator is and how to use that. Defibrillation kind of shocks the heart. It interrupts the chaotic twitching, giving the heart a clean slate to start regular normal depolarizations again. So when you kind of shock the person with the pads, that's defibrillating. So it's interrupting the twitching of the fibrillation, the irregular contractions, to kind of allow this heart to start again on a normal, regular depolarization. A defective SA node can cause an ectopic focus, which an abnormal pacemaker will need to be, will take over the pacing. If the AV node takes over, for example, if your SA node is not functioning, it sets the junctional rhythm at about 40 to 60 beats per minute, which is a little bit slower. And extrasystole is a premature contraction where, again, if we have a defective SA node, the ectopic focus of the small region of the heart will trigger the impulse before the SA node can, causing a delay in the next impulse. So the heart will no longer have time to fill. So the next contraction will be felt more as a thud as larger volume of blood is being pushed out. And this can be from excessive caffeine or nicotine. To reach the ventricles with the SA node defectiveness, the impulse must pass through the AV node. And for example, if your AV node is defective, so kind of a separate issue, it could cause what we call a heart block. So again, your AV node is the only kind of connection to the AV bundle, which will eventually bring the electrical signal to the ventricle. So if we have any sort of block in the AV node, or if it's defective, it means few impulses, which will be a partial block, or no impulses, which is a total block, will reach the ventricles. So the ventricles will beat at their own intrinsic rate that they kind of start themselves, but it's too slow to maintain adequate circulation. So anytime we have an AV defectiveness, AV node defectiveness, that will lead to a partial or total block, meaning the ventricles will sometimes beat on their own or not at all. And the treatment is to put in an artificial pacemaker, which is a little device that usually sits under your clavicle. And then there's a metal lead that comes out of it, and the metal lead will kind of travel through the defective area in this electrical signal. So in this case, that metal lead will travel through the AV node to connect the AV node or the SA node to the bundle. So if our AV node is defective, we'll kind of have a little metal lead. So the device of a pacemaker is usually inserted outside of the heart, and then the metal lead will travel from the SA node through the AV node to the bundle to just bypass the blockage or the defective AV node. And that's what a pacemaker does. Very common and very helpful, which will just, and again, the artificial pacemaker just recouples or connects the atria and ventricles together again. The heartbeat is modified by our autonomic nervous system by centers in our brain, the medulla oblongata. We have a cardio-acceleratory center, which can stimulate your SA and AV nodes to increase the heart rate and force, or we have a cardio-inhibitory center due to parasympathetic stimulation, which will inhibit and decrease the heart rate. Electrocardiography is important. An electrocardiograph, or an ECG, can detect electrical currents generated by the heart, and an electrocardiogram is the actual ECG or EKG in German. The cardio is spelled with a K. It's a graphic recording of electrical activity, which is a great diagnostic measuring tool in medical settings. It's composite of all the action potentials at a given time, not a tracing of a single action potential. To get the ECG, we place electrodes at various points on the body to measure voltage differences that are picked up by the skin that are coming from the heart itself. And we usually use 12 leads placed throughout the body, and that's the most typical. These are the main features of the electrocardiogram, which you should know well. The P wave that we see, and I'll show you a picture of this, stands for depolarization of the SA node and the atria. So this will occur right before the atria contract. The QRS complex stands for ventricular depolarization and atrial repolarization. So the QRS complex will occur right before your ventricles contract. The T wave stands for ventricular repolarization. And then we have intervals and segments between kind of those complexes where the PR interval is beginning of atrial excitation to beginning of ventricle excitation. The ST segment is when the entire ventricular myocardium is depolarized and contracting. And then the QT segment is the beginning of ventricular depolarization through ventricular repolarization. So this is where we place the 12 electrodes on the skin to record an ECG. The round antenna near the patient's left shoulder is actually reading his pacemaker data. So he has his pacemaker inserted there. So they're reading how the pacemaker is functioning too. So here's the electrocardiogram tracing, and the labels identify the 3 normally recognizable waves and the important intervals. And again, you should know what the P wave stands for, what the QRS wave stands for, and then the T wave. So knowing what each wave stands for and what happens at each wave. One thing to note at the base, so at the base of the S, right after ventricular depolarization, the pressure, so right after ventricular depolarization, so right after this QRS complex, the ventricles will eject their blood. So the pressure will be at the lowest, and then starting at this S point, pressure in the ventricles will start to increase again, and that might be important to know too. So here we have kind of the events of the electrical activity of the heart, and it highlights where each event occurs on the graph. So SA node stands for the pacemaker, starting the electrical activity of depolarizing the heart. So atrial depolarization occurs, which is initiated by your SA node, causing the P wave. With the atrial depolarization, when it's completed, the impulse is delayed at the AV node, and this PR interval, or this area that's being highlighted right here, that shows the delay that's occurring before the ventricles will depolarize, which is shown by the QRS complex. This kind of space between the P wave and the R wave, it's called the PR interval. If it's delayed too long, and in some graphs, they'll show this section is longer than it should be, that can be indicative of some sort of blockage occurring in the AV node. So if the PR interval is a little bit longer than it should. Then the QRS complex stands for ventricular depolarization. It begins at the apex of the heart, causing the QRS complex, and atrial repolarization will also be occurring in this QRS complex. Ventricular depolarization will be complete in this ST segment, and then ventricular repolarization begins at the apex, causing the T wave when the ventriculars kind of go back to normal. Ventricular repolarization is complete at that segment. So again, this is a great graph to show you depolarization, repolarization, and how they each occur using the ECG as a measuring tool. Any change in the pattern or timing of the ECG. So we can measure, usually with little boxes, how long each segment is between the P wave, the QRS complex, or the T wave. And if there's any kind of change in what is normal in the length of time for each to occur, any change may reveal a diseased or damaged heart or problems within the heart's conduction system. And again, if you have a problem with this conduction system that's picked up with the ECG, that will be a great diagnostic tool because it tells you, the heart is not contracting as it should. And if it's not contracting exactly how it should, it means that the rest of your body isn't getting adequate blood supply that it needs. Problems can be detected. An enlarged R wave could indicate an enlarged ventricle. An elevated or a depressed ST segment usually indicates cardiac ischemia or a cardiac scar tissue forming. So this could lead to a myocardial infarction or a heart attack. A prolonged QT interval will reveal a repolarization abnormality that could increase the risk of a ventricular arrhythmia or any abnormality in the ventricles contracting and electrical activity. And the next 4 slides are kind of word for word exact pictures that will be on your next lecture exam. So you should know what a normal sinus rhythm ECG tracing looks like. So this is normal. If we label things here, we can see the P wave. So that's your P wave. You see the QRS complex, the big triangle, and then the T wave is the wave after that. You see the P, QRST, P, QRST. So everything you can see is normal rhythm. So there's no gaps in between. Everything is exactly how it should be. The length, the little squares each square is about 0.16 milliseconds. So ECG readers in hospitals will make sure that everything is exactly how it should be. So this is normal ECG rhythm. Some abnormalities are shown in the following slides. Junctional rhythm. So you should know what this looks like. This means that your SA node is non-functional, and as a result, we don't have any P waves. So you'll notice here we have a QRS complex and then a T wave, but then you'll notice it's just flat here. So this means that the ventricles are starting their own heartbeat basically, and the AV node will pace the heart much slower than it should be. So this is junctional rhythm, no P waves, and the SA node is non-functional. A second-degree heart block is when the AV node fails to conduct some of your SA node impulses. So what we'll see here, and I'm just going to label some of these. Let's start with where we see something normal. So here we have a P wave, which stands for atrial contraction, the QRS complex, and then we see the T wave. So that's pretty normal so far. That's a PQRST complex. So I'm just going to kind of label that. That's our one heartbeat. The next heartbeat, we see a P wave start again, but what do you notice? After the atria contract with the P wave, you'll notice we do not see that QRS complex, meaning in this heartbeat, we are not getting a ventricular depolarization and a ventricular contraction. So this means there's some sort of blockage going on between our atria and ventricles because the ventricles aren't getting that signal to do our PRS complex to contract. So in a second degree means there's 2 P waves for each QRS complex. It's a ratio of 2 to 1. So we see a P QRST normal, but then the second P is not normal. And then it will repeat itself. We see a P wave QRST complex, which is normal. That's one heartbeat. But again, the second P wave that comes through, there's no QRST complex. So a second degree heart block means there's 2 P waves for every each QRS wave. And again, you should know what that looks like. And then ventricular fibrillation is usually easy to spot because it just looks like a toddler scribbling up and down, up and down. It's probably the worst possible thing you could see on an ECG because you see that the electrical activity is completely disorganized, random. There's no sort of reason or rhyme or reason for what's happening in your heart, it will result in a chaotic, grossly abnormal ECG deflection. It can be seen in acute heart attack or after an electrical shock. But if we don't get this back into rhythm soon, the person will eventually die. Okay, so mechanical events of the heart. So those were the electrical activity of the heart. And now let's look at the mechanical events of the heart. The mechanical events of the heart include systole and diastole. Systole is the period of the heart contracting, and diastole is the period of the heart relaxing. And those two words will come up again in the next chapter when we talk about blood pressure. The cardiac cycle itself are all of the events of blood flow through the heart during one complete heartbeat. So they include systole, diastole of the atria, of the ventricles. The cycle represents all pressure and blood volume changes. Sorry for the little pause there. I had to sneeze. I don't think anyone wanted to hear me do that. So there's 3 phases of the cardiac cycle following the left side, starting with total relaxation, which we're going to go over now. And again, all the mechanical events will follow electrical events. So what that means is electrical depolarization has to occur through the heart, meaning we have to electrify the heart before it contracts. So that's what it means when electrical events are first and then mechanical events will follow. So ventricular filling, this is mid to late diastole, so kind of the relaxation. This is where the pressure is low. About 80% of blood passively flows from the atria through open AV valves into the ventricles from the atria. Our semilunar valves are closed at this point because no blood is being ejected. Atrial depolarization will trigger atrial systole, which is the P wave, making the atria contract and kind of squeezing the remaining 20% of the blood into the ventricle. The end diastolic volume is the volume of the blood in each ventricle at the end of ventricular diastole. Depolarization will then spread to the ventricles, and after the atria finish contracting and return to diastole, the ventricles will begin systole or begin their contraction. Isovolumetric contraction means the volume of the ventricles is the same. Atria will contract, ventricles begin to contract. The rising pressure within the ventricle closes all the valves, the AV valves. And this isovolumetric contraction phase is just a split-second period when all the valves are closed, the volume remains constant, but the ventricles start to contract, which builds up pressure, which is important for the volume of blood that they will eventually eject. When your ventricular pressure eventually exceeds pressure in the large arteries, that forces the semilunar valves open, and the pressure in the aorta will reach about 120 millimeters of mercury. Then the isovolumetric relaxation phase, early diastole, follows the ventricular repolarization where the ventricles relax, and end systolic volume is the volume of blood remaining in each ventricle after systole. The ventricle pressure will drop, causing backflow of the blood from the aorta and the pulmonary trunk, which will then trigger the semilunar valves to close. The ventricles are completely closed chambers momentarily, and this is referred to the isovolumetric relaxation phase. Iso means same volume, where volume doesn't change in the ventricles yet. The closure of your aortic valve raises aortic pressure as the backflow rebounds off the closed valve cusps. This is referred to as your dicrotic notch. You don't really need to know that. The atria will continue to begin filling during ventricular systole, and then when atrial pressure exceeds ventricular pressure, your AV valves open again and the cycle will begin. Your heartbeat is about 75 times per minute. The cardiac cycle lasts about 0.8 seconds, and you can see how long each period lasts there. So this is a great picture showing the events of the cardiac cycle, the mechanical events with the pressure and volume changes between the left ventricle, the left atrium. We can also see down here the heart sounds, and the heart sounds are important. These are the sounds that a doctor will listen to with his stethoscope. The first heart sound, this doctor will hear the lub sound. So if you think about lub dub, lub dub, lub dub, the first heart sound is caused by your AV valves closing, and the second heart sound is caused when your semilunar valves close. And between the closing of those valves, you'll see how the pressure is increasing and then decreasing as it's being ejected. This then adds in the ECG element of it. So kind of the bottom 2/3 are all of the mechanical events of the heart. And then the top is showing the electrical events and how they occur with the P waves right before atria contracting. The QRS complex is right before the ventricles contract, and then the T wave. And again, you'll notice at this point in the graph, you'll notice that the pressure is always lowest in your ventricles. And that's really important to know. That might be a question on your test, that at the base of that QRS complex, the pressure is the lowest at those ventricles. And that's because it's right before that they will contract and increase and eject their blood. So the heart sounds, the two sounds are associated with closing of the heart valves, which you should know. The first sound is the closing of your AV valves, and the second sound is the closing of your semilunar valves. There's a little pause between the lub-dub sounds, and that indicates when your heart is relaxing. The mitral valve always closes slightly before your tricuspid. The aortic semilunar closes slightly before your pulmonary valve, and there's a little difference which allow the auscultation or the hearing of each valve when the stethoscope is placed in 4 different regions of the heart. So the doctor can actually hear for each individual heart sound, even though the AV valves are closing at about the same time. Depending on where the doctor listens to, he can hear slightly the closing of both. A heart murmur then isn't any abnormal heart sound heard when the blood hits an obstruction. It usually indicates a valve problem, like an incompetent or insufficient valve that is failing to close, allowing backflow of blood into a chamber that it shouldn't be happening. It causes a swishing sound. So normally the heart murmur sounds like a swoosh in a stethoscope, and that's because the blood is regurgitating and swishing backwards from a ventricle into an atria passing a valve. A stenotic valve means that it's failing to open completely, restricting blood flow, and this will cause more of a high-pitched sound or a clicking sound as blood is forced through a narrow valve. Cardiac output is the amount of blood pumped out by each ventricle in 1 minute, and you won't have to do any calculations, but you should know that cardiac output is equal to your heart rate times your stroke volume, and the stroke volume is the volume of blood pumped out by one ventricle with each beat. So if we multiply the stroke volume, how much volume is pumped out with one beat, and then multiply by our heart rate, we'll get the total volume pumped out of each ventricle in 1 minute. Maximum cardiac output is about 4 to 5 times resting cardiac output. So again, you know, if you're exercising, the maximum cardiac output can reach up to 35 liters per minute in a trained athlete. The cardiac reserve refers to the difference between resting and maximum, and cardiac output can change if either or both stroke volume or heart rate is changed. So cardiac output is affected by factors leading to things that regulate the stroke volume and regulate the heart rate. So these are all things that can increase cardiac output, that it will increase stroke volume, so the output of blood per beat, and also the heart rate, which is usually increased with sympathetic activity or decreased with parasympathetic activity. And that can be due to exercise, fright, anxiety, or a decrease in blood pressure. Regulation of stroke volume, again, I don't think there's many calculation problems on your next exam. The stroke volume is equal to end diastolic volume minus end systolic volume. And there's 3 factors that affect the stroke volume. And again, stroke volume is the amount of blood ejected per beat. It can be the preload, contractility, or afterload. Preload is the degree of stretch of the heart muscle, which just means the degree to which the cardiac muscle cells are stretched just before they contract. It has to do with venous return, the amount of blood returning to the heart. Slow heartbeat and exercise will increase venous return, and that will increase stroke volume and increase cardiac output. Contractility is contractile strength at given muscle length. The increased contractility will lower end systolic volume, which you guys don't really need to understand all of this. It has to do with sympathetic innervation. And then afterload is the back pressure exerted by arterial blood. Afterload is the pressure that the ventricles must overcome to eject the blood. It's always is from arterial blood pushing on your semilunar valves. Hypertension, so high blood pressure, increases afterload, which results in increased and systolic volume and reduced stroke volume. So that's why high blood pressure is dangerous, because it's kind of pushing back on the blood that the heart is trying to eject. So here are things that can also determine cardiac output. Same graph as before. And then we'll kind of finish with a little bit of the regulation of the heart rate. Can be due to hormones. Epinephrine increases heart rate, thyroxine increases heart rate. Ions, intracellular and extracellular ion concentrations must be maintained for normal heart function, because these ions will go into and out of these heart cells to cause the heart cells to depolarize, and an imbalance is very dangerous to the heart. Hypocalcemia depresses the heart, so too little calcium. Hypercalcemia, too much calcium, increases the heart rate. Hyperkalemia and hypokalemia have to do with potassium levels, and they can also lead to some sort of heart block, cardiac arrest, or an arrhythmia. Other factors that influence heart rate is your age. So fetuses have fastest heart rate, declines with age. For some reason, females have a faster heart rate than males. Exercise will increase the heart rate, although a trained athlete can have much slower heart rate. And what I mean by that is, if you are a marathon runner, you know your heart is a muscle. And if you exercise your heart muscle will eventually be able to do more at a much lower capacity than someone who never works out. So trained athletes can sometimes have very low heart rates because their heart is accustomed to working and doesn't need to pump as much to get the blood out. Body temperature, the heart rate can also increase with an increased body temperature. And then some of these words you should be familiar with. Tachycardia is an abnormally fast heart rate, anything higher than 100 beats per minute. It could lead to fibrillation if persistent. Bradycardia is an abnormally slow heart rate at about 60 beats per minute. It may be desirable in endurance training, but it could also result in grossly inadequate blood circulation in a non-athlete. Congestive heart failure, you should know this is a progressive condition where the cardiac output is so low that the blood circulation is inadequate to meet tissue needs, and it usually reflects a weakened myocardium, so a weakened muscular wall of the cardiac tissue due to coronary atherosclerosis, which is usually clogged arteries caused by fat buildup, impairing oxygen delivery to cardiac cells where the heart becomes hypoxic. With not enough oxygen present, it will contract inefficiently. Persistent high blood pressure can lead to congestive heart failure, multiple heart attacks where the heart becomes weak as contractile cells are replaced with scar tissue, or dilated cardiomyopathies when the ventricles stretch and become flabby and the myocardium will deteriorate. Sometimes drugs can play an effect, or chronic inflammation can also play a role. Congestive heart failure, either side of the heart can be effective, but the left-sided failure will result in pulmonary congested, where blood will back up in the lungs, and the right-sided failure results in a peripheral congestion where blood will pool in your body organs, causing an edema. Failure of either side will ultimately weaken the other side because it will lead to decompensation, which will seriously weaken the heart. The treatment is you can remove fluids which have been building up. You can take drugs to reduce the afterload, the pressure against the heart that's trying to, eject the blood, or drugs that will try to increase contractility of the heart. So that's congestive heart failure. I'll end with that for chapter 17. Thanks for listening, guys, and take care.